Well, we made it. This week we get to talk about birth physiology, also known as parturition. This is Katrina Wu, and I'm really excited that I get to be the one to give you your first taste of birth in this program. So let's dive in. I'd like to start with this quote by Barbara Katz Rothman. Birth is not only about making babies. Birth is about making mothers. Strong, competent, capable mothers who trust themselves and know their inner strength. That summarizes so well what we want to do as midwives, really allowing patients to be themselves in labor and experience just how strong they are. I still remember the first birth where this really hit home for me. It was a home birth with this mom, and she was just a rock star in labor, so strong. In her last 3 hours, she just roared through every contraction, and not in like a way that was like, I'm out of control, but more, there's just like so much power surging through me that some of it's having to leak out my mouth. And she just reminded me of a lion, and we had to drink a lot of tea postpartum. And for my part, there just wasn't a whole lot of interference. We just supported her, and she had her baby. And it was maybe a week later we were chatting, and she was having a lot of breastfeeding struggles. And I was just checking in and seeing how she was doing with just coping with the hurdles around breastfeeding. And she said, you know, Katrina, I really feel like I'm doing fine because birth showed me just how strong I am and that I really can do anything. And I think if I hadn't had the birth that I had, then this would be really hard and overwhelming. But I feel like, breastfeeding is just going to be a first hurdle among many parenting challenges down the road. And I feel like I now always have my birth to look back on to remind me just how strong I am and how capable I am as a mother. So that right there is our goal. So let's go ahead and dive into the physiology of labor and birth. So we'll start by going over different theories for labor initiation and the physiology around how that occurs. And then we'll get into maternal physiologic adaptations to labor and birth, how different body systems are adapting and adjusting to accommodate labor. We'll address physiologic changes in the third stage of labor, and then facilitating maternal and infant attachment. So first, the 4 P's of labor. Powers is essentially the uterus helping to push the baby out, along with maternal effort being combined with that towards the end to help push baby out. So we have a passenger, which is the baby who's navigating their head through the pelvis to get out. And then we have our passage or pelvis, which we've already addressed in this course a fair bit in the context of birth, remembering that relaxin helps it to be able to shift and open even up to an extra 2 centimeters to help make way for the passenger. And then, of course, psyche can also influence labor. Does she feel safe? Does she feel strong and supported? That mind-body connection piece certainly plays a role in labor as well, and heavily influences hormones. So how does labor start? So there's quite a few theories here, and we're just going to talk through some of the more common ones and look at some of the physiologic dynamics going on in this time. So we have the fetus with their hypothalamus and adrenals. They're doing a final burst of preparation for development to ensure baby's ready, and then those same hormones are also sending a message to mom's brain to say, hey, I'm ready for this. I'm ready to come out. Both the amniotic membranes and the placenta also give off hormones that help for preparation, prostaglandins, especially from the membranes that'll help with cervical ripening. And then mother's hypothalamus will also play a role. And again, this isn't completely understood, but there's numerous mechanisms here. So let's get into it by looking at some of these pictures more closely. So throughout the vast majority of pregnancy, we're in this quiescence phase at the beginning here, where progesterone is dominant. So we have all these inhibiting factors keeping us from giving birth. So even if oxytocin was being released, the act of progesterone on smooth muscle, specifically the smooth muscle of the uterus, to keep it relaxed, is going to keep that baby safe inside. You do also have these other hormones, relaxin, prostacyclines, that are also helping maintain quiescence. And then again, progesterone's the big player here. And then this activation phase is when the body is starting to become a little bit more receptive to the prospect of labor. So estrogen is forming more gap junctions on the uterus to help prep it for being able to do contractions in sync. They might start to notice some Braxton Hicks contractions or practice labor. Progesterone may start to dip. She might notice that in the form of having diarrhea or looser stools. again showing that that smooth muscle relaxation piece is starting to diminish some, which means that food can travel through intestines faster, so that can be a sign that the body's starting to become more receptive and preparing for birth. Prostaglandins are being released to start to soften the cervix. Baby's releasing cortisol, which is basically sending a message to mom that says, hey, I've got these stress hormones on board, I'm preparing my lungs, I'm ready, I can do this. And then stimulation is labor itself. So we continue to have that role of prostaglandins that can help to initiate contractions as well as get that cervix fully ripened. And then oxytocin is obviously our biggest player here in helping coordinate these regular contractions where the uterus is able to beat all as one together, similar to a heart, thanks to all the gap junctions that estrogen helped to put in. And then the birth itself would happen. And then involution is the uterus coming back down to size. So oxytocin is what helps the uterus come back down to size. And there's a lot of inflammatory cell activation changes that would happen within that too. Thrombin helps with clotting to make sure that we don't continue to bleed from the placental site. So now let's go through a couple flow diagrams together. So this one's from your COAD textbook. You can see here it's starting at the level of the fetal adrenal glands, making both DHEAS and cortisol. Cortisol is going to help the promotion of fetal lungs, and then DHEAS is going to trigger more estrogen to be released by the placenta. So estrogen is going to help make more gap junctions on the uterus. It's going to make the uterus more receptive to oxytocin by forming more receptors for oxytocin on the surface. And then it's going to also help with increasing prostaglandin synthesis. Prostaglandins will especially help with softening of the cervix, and between the cervix softening and the head causing more pressure on the cervix, that's also going to play a role in increasing oxytocin release from the posterior pituitary gland. So you can think about where are all these hormones coming from. Our DHEAS and cortisol are coming right from baby's adrenals. Estrogen's being released by the placenta. DHEAS also triggers progesterone to go down. So DHEAS is helping estrogen to increase and progesterone to start to dip. And then oxytocin's coming from the maternal posterior pituitary gland. And here is a diagram from your Blackburn textbook that's pretty similar. So you can see that left column is fetus, the center column is the placenta and membranes, and then the right column is the mom. So starting at the level of the hypothalamus, you see that the hypothalamus is releasing ACTH, which then tells the fetal adrenal glands to release cortisol and DHEAS. Cortisol is helping prepare baby for extrauterine life. And then DHEAS is starting that cascade that leads to more estrogen. If you remember, estriol is the estrogen that's most prevalent in the placenta. And that's forming more oxytocin receptors on the uterus. And increasing gap junctions also helps make the uterus and cervix more receptive to prostaglandins. And then over in cortisol, you can see that that went over to the placenta to help with oxytocin, prostaglandins, and placental CRH. CRH is corticotropin releasing hormone, so then that's just going back to the fetal adrenals to encourage it to release more cortisol. And then in that maternal column, you see that the posterior pituitary gland for mom is releasing oxytocin. So there's a little bit of placental oxytocin coming from the placental. The bulk of it's going to come from mom's posterior pituitary gland. And then everything else has been acting on it. So estrogen's been acting on the uterus for gap junctions. Prostaglandins are softening the cervix. So the goal is to prime that uterus so that it's ready for labor. Uterine stretch plays a really big role in this as well. So the more the uterus is stretching, the more gap junctions are forming and the more oxytocin receptors are forming. So I like to tell patients that it's kind of like the larger your uterus gets, the more baseball mitts start forming. Those are our receptors on the surface of the uterus. So the more baseball mitts are there, then the more oxytocin it's able to catch. So if you don't have a uterus that's very stretched out yet, you could dump all the oxytocin you want, but you can only catch so much of it if you don't have very many mitts. So as we stretch and stretch and stretch, we get more and more receptors so that when you do run PIT, if you need to in the hospital, or when it starts being released endogenously, the uterus is ready to be receptive to that and roll with it. And you can see how this would increase a person's risk for preterm labor if they had multigestation, so twins or triplets. They're going to stretch out faster and sooner and form more gap junctions and more oxytocin receptors sooner, as well as polyhydramnios. So that stretch is part of that trigger for why they might go into labor sooner. So coming back here to progesterone dipping at term. So more than anything, it's a functional withdrawal, and the mechanism for this is a little bit unclear, but levels are still fairly high, but they don't seem to be able to function at the uterine level the way they did in pregnancy. They don't have the same effect. Different body systems essentially become less responsive to progesterone, not just the uterus, but other smooth muscle throughout the body. So it's like the effects are withdrawing, but it's not as though the actual progesterone level is withdrawing. So the result of this is that there's an increase in inflammation and a decreased ability to inhibit contractions. And support for our understanding around this, RU486 blocks progesterone, and that causes an abortion or uterine emptying in early pregnancy. And then on the flip side, supplementing with progesterone can help to decrease preterm labor and preterm birth. So prostaglandins have an inflammatory effect on the uterus and also lead to cervical ripening. They're released endogenously, as we already talked about, that starts at the level of the fetal adrenals. And then that triggers the membranes of the placenta to release prostaglandins. They can also be given pharmacologically, like Cervidil or Cytotec. Those can be taken by mouth or put into the vagina. And prostaglandins are also found in semen. I remember reading one study a while back that compared women who were sexually active throughout their whole pregnancy compared with those who weren't. And those who were sexually active, on average, went into labor a week sooner than those who weren't. And it didn't increase their risk for preterm labor, but their cervix was likely riper a little bit sooner, potentially due to these prostaglandins. And orgasm would also release oxytocin, so that might contribute as well. But kind of interesting. And then prostaglandins likely also play a role in the GI disturbance that's sometimes experienced by people in early labor. So a quick summary then of labor initiation. Cervical change, that's going to occur throughout pregnancy with softening, but that really accelerates in that last trimester with PGE2, that's prostaglandin, same as Cytotec, relaxin and estrogen playing the biggest roles there. And then placental hormones stimulate oxytocin and vasopressin receptors in the myometrium and decidua. Oxytocin is released in pulses throughout pregnancy, but progesterone's impact is going to diminish that throughout pregnancy, and then it's going to cause strong contractions at term due to the increased number of receptors on the uterus, thanks to estrogen. And then uterine distension at term is also what's increasing those oxytocin receptors and gap junction formation. And then transient hypoxia of contractions at term can stimulate fetal stress hormones, oxytocin, vasopressin, and ACTH, or adrenocorticotropic hormone. And then let's just flesh out oxytocin a little bit more with this diagram. Now, oftentimes when we're talking about physiology, we're talking about negative feedback loops and how the body is maintaining homeostasis in some way. Labor is a positive feedback loop. The more contraction someone has, the more oxytocin is released. So estrogen creates more receptors for oxytocin on the uterus, and then when oxytocin is released, it's stimulating uterine contractions, it's stimulating the placenta to make more prostaglandins, and then that in turn is going to stimulate more contractions. And pressure and stretch also stimulate more contractions. That's pressure from the fetus and the membranes pressing on the uterus from inside the uterus. It's pressure on the fetal head on the cervix. If you were to put in a Foley bulb, that pressure on the cervix would also stimulate contractions. And then all of that sends a message back up to the brain, to the posterior pituitary gland, to release more oxytocin. So that's called the Ferguson reflex. Oxytocin's released, it's causing contractions, and then that triggers a stimulation for more oxytocin to be released from the posterior pituitary gland. So positive feedback loop. So altogether, that makes labor self-perpetuating. So now we're going to go through each of these organs and or body systems in order to talk about maternal adaptations to labor. So first, let's talk about the cervix. So really, its function all of pregnancy has been to protect the fetus by remaining tightly closed during pregnancy. It's composed of collagen, glycoproteins, and elastin, and it's firm in consistency. And even though it's part of the uterus, an extension of the uterus, it has a decreased number of smooth muscle cells. So progesterone isn't going to act on the cervix the way it has the rest of the uterus for pregnancy. It's able to stay nice and tight and firm and not be relaxed. So how does the cervix ripen? So the cervix is primarily connective tissue, and it really is about collagen changes. Collagen is going to change how it's linked to help it essentially stretch up and out. So there's less cross-linking and more dispersion and degradation of that collagen. Hyaluronic acid helps in that collagen dispersion as well as inflammation, and that's primarily where prostaglandins come in with inflammation. And then it's worth stressing that oxytocin is not helping with this at all. It's hyaluronic acid and prostaglandins that are helping to soften and get this cervix ready to open. So if they haven't done their work in helping rearrange the collagen fibers, adding oxytocin is just going to be causing hard contractions on a small opening that isn't capable of easily opening any further. So that's why if you do have a cervix that's very unripe, it's important to, like for an induction, to give prostaglandins first, like in the form of Cytotec or Cervidil, to get that cervix soft and ready to be opened, beginning to open before you would start Pitocin. Once that collagen rearranging has happened, even if it's not very open yet, but it's soft and it's ready, then adding Pitocin or oxytocin will help it open up. But we need to have the cervix ripe first. And then this image is showing cervical ripening, and you can see where the numbers start from that first image, and then as they progress through image B and C, that collagen rearranging itself is helping it to stretch kind of outward and up. And these pictures here show the difference between a primip versus a multip, in that a primip, their cervix is going to thin all the way out and then begin to open, whereas with a multip, it'll do the two simultaneously, where it's thinning out and opening at the same time. And you can see how if a little piece of a cervix ends up moving kind of up and out, that can create a shearing force that could be the reason for a rupture of membranes. And you can also see how in this process, the mucus plug that was held in the cervical crypts, especially in looking at that picture in the upper left corner, how it could begin to fall out in the process of cervical ripening. And for some women, they may lose their mucus plug as just noticing kind of thicker, stringier mucus discharge in the week or two leading up to labor. Whereas for others, it might come out altogether as one kind of big blob. And again, that could be as early as 2 weeks prior to them going into labor, or it could be in the midst of labor, maybe even once they're already into active labor. And sometimes cervical mucus can be blood-tinged. So as the cervix is ripening and changing and opening, there might just be a little bit of capillary breakage. So I always like to sound really excited about that because it's a sign that things are changing and shifting and that the cervix is getting ready. Or if you're finding it in labor, it's a good sign that the cervix is making good change. If I'm paged about mucus show, then I'll also sound excited, and I'll try not to imply it means that labor is imminently around the corner, because it could still be another couple weeks. But I'll sleep with my ear a little bit more open, because it's not that uncommon for somebody to call me about it, and then later that night they notice some bigger shifts, and maybe by early morning we are heading into the birth center. So it's one of those signs that tells us labor is coming, but it's not really being definitive about when that's going to be. So the uterus is composed of smooth muscle cells, and it also has a lot of collagen and glycoproteins. There's multiple layers of spiral bundles, so multiple layers of muscle, and they can contract in different directions. Hormones, particularly estrogen, as well as distension, are what induce growth. And you'll remember from the physiology of pregnancy that starts out as being hyperplasia, where you're making more and more cells, and then it transitions to being hypertrophy, where you're making those cells bigger. So cell division versus cell growth, both are happening. And these images really show you all those different layers of spiral bundling with the muscle for the myometrium. This is also a good chance to see that lower uterine segment, or the isthmus of the uterus, is present here. And there's less muscle in that area. And if a cesarean is necessary, that's where we want to be able to cut. Because with less muscle activity there, if she's in labor again in the future, that area has a much lower risk for rupture. In contrast, if the cut was from top to bottom as opposed to a low transverse incision, it actually has a 25% risk of rupture for subsequent pregnancies during labor, just because of how much muscle is in that upper part, along with the body of the uterus, and how much of that is active and needed in labor for contractions. So that would really be a contraindication for laboring again in the future if that muscle's been cut. So just again, looking at these pictures, we've got an outer layer that's got longitudinal muscle fibers, and then a middle layer that's spiral layers, and then that inner layer is more transverse, circling around the uterus. So how does the uterus contract? We're really going back to Physiology 101 here. So actin and myosin and intracellular calcium. I've got a picture on the next slide, so we'll get into that a little bit more in depth. But to recognize that we really need calcium in order to make this happen. And then we already talked about briefly that there's cell surface receptors to hormones, specifically oxytocin, and that's mediated by estrogen, with increasing receptors during stretch and throughout the duration of pregnancy. We're having more and more receptors towards the end due to distension. And then we have gap junctions within the myometrium that estrogen makes, and that's going to be an important part of contracting as well. So in this image, you can see the yellow myosin heads are going to grab onto that green actin, the little balls, and they're just going to grab it and pull it. So they'll grab and pull and grab and pull, and basically that's going to move that top rope of actin over to the left. So you'll start out with a long muscle fiber and then grab and pull, grab and pull, grab and pull, grab and pull, and that muscle fiber will get shorter and shorter and shorter. So that's what's happening during a contraction. So that requires energy, a lot of ATP, and then calcium is really the activator for all of this. And all that ATP means that you're burning a lot of calories. And then in this picture here, you can see from A, we've got our nice elongated muscle fiber, and then that myometrial cell is going to bunch up for that second picture, getting shorter and shorter and shorter because of the way actin and myosin are acting within that cell. So gap junctions are the reason that we can have one big unified contraction across all these different myometrial cells. So as the electrical impulse travels across all the cell membranes, it's able to quickly move across all of them by traveling through these gap junctions. So for this image, you can see that on one side, you have one cell membrane, and then on the other side, it's the other cell membrane. So that gap junction is connecting them. So then we have this rapid influx of calcium that's able to move from cell to cell to cell to cell quickly, helping actin and myosin make all the muscle fibers contract at once together. The only other place in the body where you'll find gap junctions is in the heart, helping to facilitate a unified beat. If you had myometrial cells all contracting on their own, it wouldn't be able to mount a sufficient unified contraction capable of moving the baby down. So oxytocin, we know that it's produced and released from the posterior pituitary gland. It comes out in a pulsatile fashion, and specifically what it's doing is it's increasing intracellular calcium levels that can then facilitate actin-myosin binding. And again, the more receptors we have, the stronger contractions, and the more unified contractions we're going to be able to accomplish. And those increase in receptors come with gestational age and uterine stretch. So how do pharmacologic agents relate to this? So to promote labor, Pitocin is a synthetic form of oxytocin, And then to inhibit labor, we can decrease intercellular free calcium. So without free calcium, you're not going to be able to have actin and myosin binding, which means you can't have a contraction. So magnesium sulfate does that, beta mimetics do that, calcium channel blockers do that. They would all be options, for example, in the context of stopping preterm labor. And then blocking prostaglandin synthesis can also help to inhibit labor. So NSAIDs, such as indomethacin, have been used for that purpose. Prostaglandins, again, make the uterus more irritable and also help to ripen the cervix. So then what's the difference between warm-up or Braxton-Hicks contractions versus labor contractions? So that top line is showing you an example of a warm-up contraction that wouldn't lead to having a baby. So the contraction, you can see that you start with a long muscle cell, and then during the contraction it shortens, and then it relaxes and it comes back all the way to the length that it was at the beginning, and then it shortens during a contraction, and then it comes all the way back to the length that it was. And the contrast to that for labor is that during a contraction, that muscle cell is going to tighten, and then once it relaxes, it does come back and elongate again, but it doesn't come back fully to what it was before. So progressively throughout labor, the baseline for how short that muscle fiber is going to get smaller and smaller and smaller progressively. Tightening and relaxing, but not fully relaxing to what it was before labor. So our unified contraction is due to gap junctions, and then also that unification starts at the top and then it wraps its way down. And you can see that in this image here, the upper right part shows how the contraction is moving both in as well as down, so kind of starting from the top and wrapping down. So then it's either the top or sometimes a little bit more to one side towards the top is serving as like the pacemaker for the rest of the uterus, kind of like the SA node in the heart. Women will typically either describe it that way or describe it as feeling like it starts towards the back and then wraps around from there. So now, what are the membranes doing in labor? So in about 5 to 10% of all pregnancies, rupture of membranes will happen prior to labor onset. And labor should follow within 24 hours for almost all of those whose membranes did rupture prior to labor. So still, the majority of the time, that'll happen in labor, usually in active labor, maybe even into transition. And then a smaller percentage wouldn't even rupture if we didn't end up rupturing their membranes for them. So those babies would be born NCOL or still inside the membranes. It's hard to have good stats on what percentage that would be, since so many of providers would end up choosing to rupture membranes prior to that point, but I've got a little handful of babies NCOL, so the possibility is definitely out there. If membranes do rupture early, the earlier in pregnancy is, the longer it may take for labor to kick in. Membranes rupturing is associated with collagen degradation in membranes. And then the act of them rupturing stimulates the production of prostaglandins in the membranes. And it also perhaps might be due to the additional pressure of the fetal head on the cervix, which is why particularly in multips, this could actually be a method for induction. And it can function as a method for augmentation for both primips and multips. So now for maternal adaptations to labor, I'm just going to run through some of the bigger body systems. We've already talked about how they have changes in pregnancy. So now how does that translate into labor? So for the cardiovascular system, there is a rise in cardiac output, and that can be altered by position as well as analgesia. There's a slight increase in both systolic and diastolic blood pressure as well as heart rate, and that's from the increased sympathetic tone during contractions. So that should go back down to baseline in between contractions. Oxygen consumption is going to gradually increase with contractions. The work and the labor of contractions is going to use up a lot of energy. We need oxygen as a part of that process. So pregnant people really are gearing up for a marathon here. If they go into labor already having some kind of arrhythmia, that may be exacerbated during labor. And then any cardiovascular changes that they do experience in labor should quickly return to baseline right after the birth. For hematologic changes, hemoglobin does rise just a little bit. This can be partially due to hemoconcentration, and it can be impacted by stress, dehydration, as well as muscular activity. And then the hypercoagulability that we already saw was increased in pregnancy is going to increase a little bit further in labor. And again, the goal being that we're ready to clot right after the placenta comes out. So that thromboplastin from the placenta and decidua helps to make a clot, and then the decrease in fibrinolytic activity means we're not going to break down a clot as quickly. And on top of that, you've got that increased erythropoietin activity leading up to labor and birth that will help to make more red blood cells in preparation for having some blood loss. So for the respiratory system, contractions are going to lead to some mild ischemia of myometrium, which will in turn lead to acidosis because of the anaerobic metabolism. It's hard to get enough oxygen there, so that can lead to some increased pain as you're thinking about pain or sensory perception in labor. And then there is an increase in respiratory rate with a tendency towards hyperventilation in labor, and that's a natural response to pain and apprehension. So not ideal per se, but not uncommon. And you'll remember that that respiratory alkalosis state with hyperventilating is already there in pregnancy, but there's a tendency to have that be exacerbated during labor. And again, we've got that low CO2 threshold. In the second stage of labor, when moms are pushing, there's also that potential for hyperventilation, especially if they're holding their breath. That has the opposite effect, but then once the contraction's done, like if they're holding their breath to push, and then when the contraction ends, they kind of need to compensate for that, so then they're hyperventilating potentially to offset that. And then you'll remember that while we have respiratory alkalosis in pregnancy that's compensated really well with metabolic acidosis to help reach a homeostasis again, there's less of a buffer potential for that in labor because of the anaerobic metabolism that's happening with the uterine myometrium. All that to say, our compensatory mechanisms aren't as in place as nicely as they are in pregnancy. So then renal adaptations, there's an increase in renin and angiotensin, and that's important for maintaining uteroplacental blood flow. So we're holding on to more fluids, we're not peeing as much. And oxytocin actually also has an antidiuretic effect. So we're ensuring that we're getting adequate blood flow to the uterus so it can do the work of contractions as well as consistent blood flow to the fetus. And then that's also a little bit protective for after the birth too, right? Because we know we're going to bleed at least a little bit, and then especially if we hemorrhage, but even if it's just normal blood loss, having held on to a little bit of extra water leading up to the birth, that helps us achieve homeostasis sooner postpartum. So that's normal and protective and is thanks to both the kidneys as well as oxytocin. The antidiuretic effect of oxytocin has the potential for water intoxication. That's really not seen with endogenous oxytocin, but if somebody had a lot of Pitocin in labor, then that would be a possibility. And these changes in labor, not surprising that metabolizing and excreting certain drugs may be affected, particularly if those drugs are relying on the kidneys as part of their metabolism and excretion process. And then, of course, there's the potential for bladder and urethral trauma during the birth itself. So that's something to keep in mind with the renal system in general. Not common, but it can happen. So for the GI system in early labor, it's not uncommon to have some more looser stools, and then gastric motility tends to decrease for most of labor. So the body's focus isn't on needing to go to the bathroom a lot. There's more likely to be delayed emptying, and the GI tract is just not going to be the focus for the body for the portion of labor. There also is a little bit of a rise in acidity of GI contents during labor. Okay, so now metabolism. Laboring people are burning 700 to 1,100 calories an hour. That's a lot. Appetite can really range, but for those who are hungry, I really want to advocate for those moms to have access to food in labor. I can't tell you how many times kind of between transition and pushing, I've had moms just come up with a voracious appetite where, they're 9, coming on 10 centimeters and their contractions just take kind of a lull getting ready for pushing, and they want a whole hamburger or scramble me 3 eggs. I need an omelet. So perhaps that's a little bit more the exception than the rule, but having lots of snacks on hand and having options and really following their lead for what they're hungry for and how often they're hungry, their body needs a lot of calories. And so if they're instinctively seeking out food, let's make sure that they have access to that. And the same goes for postpartum. There's usually a little bit of a flurry in that initial postpartum period with getting both mom and baby settled. But then as soon as they are settled, as soon as we've got that placenta out and baby's latched and things just start to calm down a little bit, I want to say, hey, what are you hungry for? I want to help you get a good meal in here. Let's start to replenish some of what we've lost. So maternal glucose consumption increases, obviously, because the uterus is using so much. So lipolysis produces ketones, which we talked about with uterine ischemia and needing to break down fat in order for getting the energy that the uterus needs. And that can potentially interfere with fetal pH and uterine activity. Anaerobic metabolism is what's producing our ketones. And then in terms of normal metabolic changes, there might be a slight increase in temperature, or it could indicate dehydration or infection. So to be mindful of ruling those out. And then, of course, encouraging her to drink something that's got some glucose in it in labor is going to be helpful for just giving her quick, easy access to more glucose to be powering her uterus throughout labor.